Hi, thanks for joining us on this interactive live Facebook feed that we're doing today, presented by Barnes Jewish, St. Peter's Hospital, and also Progress West Hospitals. Today we're going to be talking about total knee replacement. And with me is Matt Plisky. He's the certified physician assistant for Dr. John McAllister at Advanced Bone and Joint in St. Peter's. Welcome.
Thank you for having me.
So let's get right to it. We've got some great questions. By the way, you could put your comments into the questions, or put your questions into the comments section, and we'll get to them as soon as possible. During this live event, we want you to do that. And as we start talking about knee replacement, there's knee pain first. So what are some of the big causes of knee pain?
Correct. So the knee is actually a fairly complex joint in our body. And obviously what leads to knee replacement is arthritis, which is a very painful condition, which arthritis basically is breakdown of the cartilage. So our knee joint has the kneecap here, the patella, which is lined with cartilage, and then our femur, which is the big bone of our thigh, and then the tibia, all have cartilage. And arthritis is breakdown of that cartilage, which leads to instability. You can get popping and catching in the knee. When you start to have exposed bone, you get pain from that. When you start to have these bones get closer together from having arthritis, these soft tissues, which are called the meniscus, start to get degenerative tears. That's the big cause of knee pain with arthritis. Now, that's what leads to replacement. Again, the knee joint's complex. There's other conditions out there that also cause knee pain as well. You know, with somebody that might have knee pain without arthritis, you can have meniscus tears, you have external ligaments, your MCL and LCL, which is your medial collateral ligament, and your lateral collateral ligament, which can cause pain. You can have pain from the way the kneecap's tracking in the groove here of the femur, which is called chondromalacia patella. When you have injuries to your knee, you can have tears to your ACL, your PCL ligaments. So not just arthritis causes knee pain, all sorts of injuries to the knee can cause knee pain. You can even get knee pain from having pinched nerves in your low back, and actually hip arthritis can present as knee pain as well.
Okay, so the two main issues are going to be arthritis or injury when it comes to actually getting the knee replaced.
Correct.
Okay.
So arthritis can be caused from just primary osteoarthritis, which is degenerative causes. You can also have post-traumatic or secondary osteoarthritis from a previous ACL surgery or an injury to the knee that leads to arthritis years down the road, both which can lead to partial or total knee replacement.
Okay, now what are some of the things that people need to know as they're contemplating surgery? Because it's not just a minor thing.
So when I think about knee replacement surgery, when I'm counseling my patients, we're seeing them in the office for visits. We're treating their arthritis. We usually start with conservative measures, which we can talk about here in a little bit. But usually when somebody's ready for knee replacement, it's when they've failed conservative care, their knee pain starting to be debilitating and affecting their daily activities of life.
They've pretty much done everything they can do.
Right. They're not doing things. Their friends are calling them up and want to go to lunch or dinner, and they're saying they don't want to do that anymore because their knee. That's the reason they're not doing things is because their knee hurts too bad, and they've been doing these conservative measures that may or may not have worked in the before, and now they've just stopped working.
So icing and Advil just isn't cutting it anymore. It's time to get serious about this.
Correct.
And once again, please go ahead and ask us your questions. Put them in the comments section there on Facebook, and we'll jump to those with Matt here in a little bit. Now, you showed us a little bit about a normal knee. Let's take a look at that again real quick, and then we'll go to the replacement part.
So normal knee, this cartilage. And again, arthritis is breakdown of the cartilage of the joint. The one we're talking about specifically today is the knee. So you have cartilage, which is, there, it'd be easier if I pop this off.
Yeah, and that doesn't happen after on a real person.
So the kneecap here, which glides here in the trochlea, or the groove of the femur, has cartilage underneath the kneecap, so when it's gliding. Then you also have this cartilage here that lines the bone of the end of the femur, and then you have cartilage that lines the tibia down here, and these are your meniscus. So normal knee looks just like white, smooth cartilage. When you start to break down and have arthritis, it starts to almost looks like you take a cheese grater to that cartilage. Almost, it starts to fray, and then you start to get areas where that cartilage is worn down to the bone. so you can start to get little potholes or divots in there, and a lot of times when we go to open people up for surgery, that cartilage is just completely gone, whether it be only on the inside compartment or only the lateral compartment, or it could be all three or tricompartmental arthritis.
Well, how do you know before you open them up what you're looking at? I mean,
so evaluation for knee pain is obviously going to be starting with an X-ray, which normally we see the bones on X-ray, so we can't see the soft tissue such as the meniscus and the cartilage that lines the bone. But when we take an X-ray, somebody with arthritis, that space between the two big bones is going to start to get better, or the space between the kneecap and the trochlea, that's going to start to get smaller. And so once those bones start to get closer together, you can tell on an X-ray they're getting arthritis. Usually you don't need an MRI or anything like that to tell you have arthritis. You can basically tell from an X-ray. There's other changes in the bone. You can get sclerosis, which the bone starts to see pressure and gets harder, so it starts to look a little bit whiter on an X-ray, and you can get bone spurs that you can see on an X-ray as well.
is there anything that I would notice, on my own knee, if I was starting to get, the arthritic situation? So there would be kind of a telltale sign.
Somebody that thinks they're having knee pain and they might have arthritis. You might notice some angling of the knee, whether it be people call it knock knee or bow-legged. Because if you think about if you have just medial compartment arthritis, that inner compartment of the knee is going to start to get narrow, so you might have a different angle in your leg. So changes like that. You can notice stiffness in the knee. You can't straighten your knee all the way, or you can't bend it. You might notice some grinding or popping in the knee.
I was just going to ask, you maybe hear the knees popping as you're going up the stairs or down the stairs more often?
Yes, sir. And then you can also notice swelling, intermittent swelling with the knee, and a lot of times that can kind of come and go with arthritis.
Okay. Now, if what can they do to avoid surgery? Is there anything in particular they can do proactively?
So unfortunately, arthritis is kind of a degenerative problem. So over time, it's going to get worse. I usually tell my patients the only way that they're going to prevent this knee from getting worse if they were to lay in their bed 24 hours a day, 7 days a week, and that's just not feasible. So
I don't know. That sounds like a great option for me.
So basically, what we have out there for arthritis. Say you come in, for your first appointment. First time you started having pain, we know you have arthritis. Depending on whatever stage it's at, whether it be end stage arthritis and they never had treatment, or it's starting to show early signs of arthritis. We talk about, basically exercising with physical therapy. That's really good to help strengthen up the muscles around the knee, help with the stability that people might have, or help with the instability that people might have from knee arthritis. If somebody's a little overweight, working on weight is a huge thing with knee arthritis and helping with pain. So if, say somebody, loses, 5 pounds, that's like losing 20 to 25 pounds of pressure off their knee. So for every pound your knee loses about 4 or 5 pounds of pressure. There's different sort of braces out there, whether it's just a standard, off-the-shelf hinge knee brace with nice supports, or there's different types of unloader braces where, you can offset somebody that has medial versus lateral compartment arthritis and offset where that knee is seeing the pressure. There's injections. The big ones you hear about are cortisone or steroid injections.
But you're limited on the amount of those you can use, right?
So our recommendations. We wait 3 months between shots.
Okay.
And somebody with an arthritic knee, sometimes they come in every 3 months. They last a couple months, and then they wait. Have pain for a month, and they come back in. There's other types of shots. A general class of medicines called viscosupplementation, which people might have heard as rooster shots or anything, but they're made of hyaluronic acid, which is a natural component in cartilage. And those are usually come in a series of shots, and they're more of a gel, kind of natural anti-inflammatory lubricant for the knee. And then there's all these new ideas out there with PRP, the orthobiologic injections, stem cells, and bone marrow. And those are just really showing that they're helping with pain, but nothing out there is growing cartilage back.
Okay, but there are at least some less intense options that people can take a look at. And we're getting some questions here online. You had mentioned, dropping some weight, taking the poundage off of the thing. One of the questions is, does being overweight affect the surgery possibilities?
So I think this is a kind of a surgeon-dependent thing. We usually counsel our patients and will not operate and do a knee replacement until somebody's body mass index or BMI is under 40. And that's not just because they're overweight, but there's certain risks that come along with that. So, the studies are showing that once you get up around that, BMI of 40 mark, you're starting to have a double or triple increased risk of infection and cardiac events with surgery. So, we really try to maximize our patients, trying to get them, down, into a weight that's, that we're comfortable
Does that
working
also
with.
affect the rehabilitation, though?
It does. It's
Okay.
a huge, it's a huge help. We've had plenty of people that have lost weight that have done great in recovery. It just helps people move around easier. It helps them with their strength and motion afterwards. I just think it's a huge factor.
And there's going to be the physical therapy that goes
Correct.
along with it and stuff like that.
Yes, sir.
One of the other questions we just got off of our Facebook feed, can I get up the first day after surgery?
You can. So we get our patients up walking the day of surgery. So you have it at 7 a.m. in the morning, you're up walking that afternoon. We get you up moving. Usually therapy will see you that evening, and then they start right away, then post-op day 1, first thing in the morning. So, and you'll be using obviously a walker afterwards.
And some help.
And with some help, yes.
Yeah, it's one of those things where you get somebody to get you going. And this is one of the thoughts that I have on it, and I may be totally wrong, but when it comes to after the surgery, you're getting to a better situation. Is it more use it or lose it when it comes to that joint? If you don't exercise and continue to utilize that joint, does it start to stiffen up a little bit more?
We talking after surgery?
Yeah.
After replacement?
So, yeah, you've got it done, and
So that's a huge it's a huge thing after surgery with total knee replacement is you have to work hard with physical therapy. So I counsel my patients, beforehand. I explain to them that it's going to be painful. I try not to sugarcoat it, and trying to explain to them that they really have to push through some of that pain and work with physical therapy because that's a big risk of, it's not a big risk, but it is a risk of surgery is what we call arthropybrosis or basically a stiff knee. So early on is important to work on your range of motion. Once people, usually about 105 degrees of flexion or bend in the knee is a functional flexion, but we really strive to get our patients close to 120 degrees of flexion. And a risk usually around 6 weeks from a total knee replacement. When I see a patient in the office, I really if they're not getting quite to 90 or past 90, I really challenge them to work hard with physical therapy for another couple weeks and have them come back for a range of motion check. And if at that point they're not where I want them to be, we start talking about taking them back to the operating room for a manipulation.
okay,
Which basically is you put somebody out under anesthesia and you raise their leg up and you kind of pop it.
we'll fix
and
it.
break up some
It'll
of the
be
scar.
fine.
Break up some of the scar.
Yeah, and you don't want that.
Right. Yeah, there is obviously some risk of having to have that done with, bone fractures and that type of stuff. So, but usually people do really well after that. It kind of loosens up their knee. They just get back to therapy and
Do what you're told.
And then they're usually, and again, sometimes people that is something that happens even if they are working hard with their therapy. Somebody might just be more prone to form that scar tissue in their knee, and there's nothing they can do about it.
I got to tell you, I've got a lot of friends who have gone through this scenario, and they're like, surgery wasn't that bad, but the physical therapy, man, they were mean. It's like, no, they're not mean. They know what they're doing, and they got to push you. It hurts,
Right.
but you got to do it.
Now, I hear people talk about that all the time post-operatively at the office is just, that therapy is painful, and that's one of the things that will linger somebody on pain medicine is that they'll keep on it because they just use it for therapy to help them get through and get their maximum benefit out of it.
Yeah, and that's the thing is getting it going. Now, if somebody does decide to get the knee replacement surgery, what kind of anesthesia do you guys use?
So we typically use 2 different types, either general anesthesia where they completely knock you out, or you can actually have it under spinal anesthetic. So, those patients are actually still awake, but then they sedate them in the operating room. And that's all patient dependent. So prior to surgery, you meet with anesthesia at the hospital, usually within 10 to 14 days of the surgery, and they kind of go over their history with the patient, whether they have degenerative changes in their back, and whether or not they'd be a candidate for spinal versus general. They talk about the pros and cons of both, and they really leave it up to their recommendation, and then leave it up to the patient.
My recommendation is knock me out. That would be my personal thing, and it's just that's just how I feel about it. A couple of questions here also. Now, how long are patients under anesthesia typically?
So obviously every surgery is a little bit different.
Right.
So there's not a specific time frame. It's usually about anywhere from 75, I'd say, to 90 minutes that somebody would be under anesthesia. So
the surgery doesn't take that long.
Correct.
You guys have done it before. You've got a lot of practice in this, so you know what you're doing on it. Now, if somebody is looking at this, and here's just my personal question: if both of your knees are having issues, do you get them done one at a time, or knock them both out and go?
And again, that's a surgeon preference.
Okay.
I know with myself and Dr. McAllister, we prefer to do one, stage them and do them one at a time. So that's just, we think we'd rather do one, make sure somebody's happy with it, and rehab it nicely before we talk about doing the other one. We generally recommend about 3 months from one to the other. However, there are some circumstances where we can do somebody about 6 to 8 weeks.
Really, that quick?
Yeah.
That's exciting to know. Now, after they're done, after the surgery's done, what do they need to expect, that day and for the next few days right after the surgery?
So just, obviously expecting to have pain. We're actually doing some of these as outpatient now. So outpatient 1 or 2 nights in the hospital usually. Sometimes we'll have some patients linger, that extra third day. But really, as far as post-operatively, making sure they're staying on top of their pain, working with physical therapy. If depending on medical problems, we'll have either their primary care if they're affiliated with, seeing their patients here at the hospitals at Barnes or Progress, or have the hospitalist group see them, managing their medical problems. Like I said, just working with therapy until they're safe. Now, when they're ready to get discharged, there's a couple, and again, this is kind of a surgeon dependent thing, is what they do going home. Whether they go home, and go straight to outpatient therapy within the next couple of days, or if they have the home therapy and nurses come out to their house for a week or two, and then there's also the option of going to rehab facilities and that type of thing. It's kind of 3 different avenues that you can take.
I'm always the kind of guy that's like, oh, it's not hurting, I won't take my pain medication right now, and then it starts hurting, and then I got to wait for it to kick back in.
So
I learned that lesson pretty quick.
That's a big problem with knee. There's a lot of some patients, they think they're feeling okay, and then with knee replacements, that pain really comes on strong, and it's hard for them to catch back up with getting on top of it after they kind of skip some pain pills.
So again, do what you're told.
Yeah,
that's pretty much the basics on that.
And that's the nice thing about having a knee replacement surgery at a hospital like Barnes or Progress, where we have a dedicated surgery floor and the nurses deal with these patients all the time. They know what these patients need, and they really do have good recommendations as far as when they need to take their pain medicine, and they really try to encourage patients to take them, just for that reason, to make sure they're staying on top of.
Okay. And typically, you mentioned some of these are outpatient. Typically, after a surgery, how long are you going to be sticking around before you go home?
Usually. They'll stay for several hours after surgery before they were going to go home. If somebody has staying in the hospital, like I said, it would be 1 or 2 nights is typical. Majority of people are staying 2 nights in the hospital.
Okay. How we're looking at these parts.
Sure.
Obviously, they're little plastic pins holding these in.
Yeah.
How are they actually held in real life?
So this is a model of a total knee replacement. Again, they all are. There's lots of different companies out there that make knee implants. They all have a lot of very similar things with them. They all kind of generally look the same, but have a little bit of subtle differences. So depending on which surgeon you use and which company in knee implants, you can have cemented knees or cementless knees, which are press fit. Dr. McAllister and myself, we cement our knees into the joint. So this is actually what a knee replacement looks like. You can see how this. I don't know if you can really tell, but this is the metal compartment that ends up lining the femur here. And then you have a new tibial plateau here, and with a small stem that goes down into the bone, and then the plastic or the poly that this glides on and moves on is snaps into that tibial component. And we personally use cement. We cement our knees in both to the femur and the tibia, and then actually, depending on when you get in, if somebody has wear and tear underneath that patella, you can put a little plastic button and resurface that where it articulates with the metal of the.
But you put the
joint.
kneecap back, right?
Yeah, so you'll always have your own kneecap bone. It just depends on whether or not we will resurface with a little plastic button.
Okay.
And that just depends on when we get in there, if somebody's the cartilage of their kneecap is bad or not.
So what are the success ratios on this? Failure to success?
Well, so total knee replacement is obviously a very common procedure, and it's a very successful procedure. There's some statistics out there that say well over upper 90% are still in over 10 years. I think 85 to 90% or so are in there at 20 years now, are still in from the primary knee replacement. Wow. So it's obviously there are things that will require revision. Which infection postoperatively can lead to revision. Over time, wear and tear of the plastic that sits here between the knee joint can lead to revision. there's things that lead to it, but again, it's not very common, and
Okay.
it's a very successful surgery.
Well, you mentioned infection. So what are the statistics regarding infection after a surgery?
It's about 1 in 150 to 1 in 200 with total knee replacements. So it is a risk. We do everything we can in our down in the operating room for sterile technique and all that, and you get IV antibiotics at the hospital before and after the procedure to help with that. It's just one of those things that with putting metal and plastic in somebody's joint that is a risk.
But it's not necessarily any higher than any other type of surgery.
Yeah, I mean,
typically.
anytime you cut the skin, there's a risk of infection. Introducing bacteria is so. It's there.
Yeah. Well, we're talking about revisions. Typically, how long? You mentioned there are some that are in for 20 years. Is it something people have to look at? Okay, I'm in my 40s. I'm not. I don't need to do it now because I'll have to have it done again in 20 years, and I don't want to do it when I'm in my 60s. Or is it that just a myth?
So we do obviously. We basically treat the patient, not necessarily an X-ray. We've done people in their 30s and 40s, and we've done people in their 90s. There's really not a good time to do it, or a time frame that you should do it. Look at, say somebody is 50. You put in a knee replacement. Chances are when they're 75 or 80, they might be looking at some sort of revision surgery. They're hoping that these implants now are lasting about 20 to 25 years. They started infusing the plastic or the poly with vitamin E to help maybe keep the longevity of those implants a little bit longer. So, and again, like going back to partial versus total knee replacement, if somebody has just primary, one compartment arthritis and you do a partial knee replacement, the revision to a total knee might happen, 15, 20 years down the road, but it's a much simpler surgery.
Well, and the quality of life between, oh, these really hurt, I'm going to wait 10 years. How many times have you heard people go, oh, I wish I would have done this 5 years ago, 10 years ago?
We hear that quite a bit. I don't have a good number on that, but whether 8 out of 10 people or whatever, but it's very common that somebody's, is very pleased with their surgery and, says that they wish they would have done it earlier.
Okay. We've got about 5 minutes left, so if you have a question, go ahead and put it in the comments section. You can also call 636-524-0806 if you have more questions, and we can get some more detailed answers for you. One of the things that people have been asking about is how they should prepare the home for after surgery. What do they need to do to get ready to make it more easily accessible for them?
So a big thing would just be rugs on the floor with a walker. That's a big one. They do a lot of that counseling with the occupational.
You mean take the rugs off the floor?
Yeah.
Okay.
Yeah. So when you're going home, they're going to be using a walker. So any sort of trip hazards would obviously be something to look out for. There's nothing. We don't usually use any sort of raised toilet seat or anything like that. We don't need any sort of beds brought into the first level of the home. They teach you how to do stairs before you leave the hospital. So if somebody goes home, if they want to spend the first few nights on the first level and a recliner on the couch, I think a lot of people probably do that before they make that trip up, if their bedroom is upstairs, up to their bed. But there's really not too much that really needs to be done with the house. I mean, and again, I think the occupational therapy here at the hospital, when they're seeing them, kind of go over a lot of that stuff with them.
Okay, but there's nothing they have to build a ramp so they can get themselves up the block and tackle or anything like that.
No, sir.
We don't want that. That wouldn't be fun. Couple of more quick questions that we have for you. We're talking about restrictive activities with stairs. What about driving? When can you typically get back? I know everybody's different, but normal.
Well, one thing, obviously, a limiting factor would be narcotic pain medication. So if somebody is still requiring pain medication at a certain point, they obviously have to be off of those before they start driving. With the left knee, as long as they're not dealing with any sort of clutch, anywhere from 2 to 3 weeks. If it's the right knee, I try to get people to wait till about 4 weeks from surgery.
Okay.
So, and again, some patients that are a little bit different there, but I try, if I can, to keep somebody for about 4 weeks with the right knee, and it also depends on how well they're doing.
And that's, again, do what you're told, do your physical therapy.
Right.
Is there any kind of testing that you guys do? I mean, how often do you see them after the surgery?
So we obviously see them when they're in the hospital on rounds, but then we see it typical, as long as we don't have any circumstances where we need to see them any sooner, we see them about 2 weeks, 6 weeks, and 10 weeks.
Okay.
And then after that, we see them at a year. and then we do yearly about every 5 years after that.
Just to make sure everything's
Correct.
Still lubed up like it needs to
You
be.
got it. Yeah,
Okay.
and then like I said, obviously we'll see them any sooner if we need to for any issues.
Okay. And the most important question, will the joint replacement cause the metal detectors to go off?
It will.
And then what? Then what do I do?
It will. There's actually nothing that we can do anymore that gets people through that any quicker, through any security any quicker. So we basically just tell them to have a replacement, show them their scar. They're going to get wanded down. Now I have heard though that if you do like through an airport, if you go through the whole body scanner, that will pick it up and there's no issues. They won't pull you aside or anything. So.
But you'll have also really cool x-rays to show people. This is what I have now.
Yeah.
Matt, is there anything else you think we need to go over? We've got probably about less than a minute.
No, if anybody else has any quick questions, shoot them in the comments. But otherwise, I think we covered quite a bit.
Okay, I think so too. Thank you so much.
You're very welcome. Thanks for
now,
having
folks,
me.
if you're interested in learning more, schedule a consultation with Matt or one of the other orthopedic experts. We'll include the link in the comments section. Again, that phone number is 636-524-0806. Matt, thank you.
Thank you very much.
I learned stuff. So it was great. Again, and thank you for joining us for this live Facebook event presented by Barnes Jewish St. Peter's Hospital and Progress West Hospitals. I'm Brian Richardson, and we're glad that you came along with us.